Welcome, this is Dinah Miller. This is part 4 of CPT coding for the new codes for 2013 for outpatient psychiatrists for psychotherapy. This is the final part in this series. I'm going to talk about the outpatient codes for established patients to replace the psychotherapy portion of 90804, 90805, 90806, and 90807. This presentation is not endorsed by any professional society or organization. The next few slides were shown in the past 3 parts. This is who I am. The next slide is my disclaimers. This slide says that I don't agree with the changes that are being implemented and points you to an article. And now I'm going to talk about psychotherapy codes. Psychotherapy codes are determined by face-to-face time spent with the patient and/or the family. There are 3 timed levels of psychotherapy: 30 minutes, 45 minutes, and 60 minutes. But what is time anyway? A 30-minute session lasts 16 to 37 minutes, a 45-minute session lasts 38 to 52 minutes, and a 60-minute session lasts over 53 minutes. And if you want to look at the current Medicare reimbursement rates, you'll find that you get paid significantly more if you see a patient for 53 minutes rather than for 52 minutes. So the first thing I'm going to talk about is psychotherapy without medical services. These are codes that will also be used by other mental health professionals who do psychotherapy. And they're comparable to the 90804 and 90806 codes that psychiatrists have been using, meaning psychotherapy without medication. So the code for 30 minutes of psychotherapy, meaning 16 to 37 minutes, is 90832. 45 minutes is 90834, and 60 minutes is 90837. There is the assumption that psychiatrists may not use these codes very often. So for psychotherapy with medical services, before you code the psychotherapy, the first thing you're going to do is determine the E&M code for the medical service. And for established patients, these codes are 99211 and 99215, and we talked about them in detail in part 3, so if you missed that, go back to part 3. From there, psychotherapy is an add-on code, and anything that's an add-on code needs a plus sign in front of it so that you're adding it on. So the session will require 2 codes, one for medical management, which will be an E&M code with all the required documentation, and a second psychotherapy code, and psychotherapy codes are not E&M codes. You are expected to document the psychotherapy and what happens, but it's not got specific bullet points you need to look at. Okay, so psychotherapy as an add-on code has a different number, and remember you need to use the plus sign. 30 minutes is 90833, 45 minutes is 90836, and 60 minutes is 90838, with E&M codes 90785 for situations with emotional family members present, the reporting of a sentinel event such as abuse, or complex situations requiring translators, but I was told last night that the translator issue is a little stickier. I'm not sure quite that that's a valid use of it. And if you use an interactive complexity code, that would be a 3rd code added on to the E&M code plus the psychotherapy code. Next, I'm going to talk about psychotherapy crisis codes, and I have to tell you that I have not researched this in much detail, so I'm just going to read you what I read. Psychotherapy for crisis services is 90839, crisis for the first 60 minutes, and then you add on 90840 for each additional 30 minutes. And I forget the exact numbers for what makes it 60 minutes, but of course it's not 60 minutes. The 90839 is not an E&M code. it's used to report total duration of face-to-face time with the patient and their family providing psychotherapy for a crisis. The time does not have to be continuous, meaning the doctor can leave the room to arrange for hospitalization or other services, but the provider must devote their full attention to the patient and cannot be providing services to other patients during that time period. And I think crisis is defined somewhere, but it's not a patient being distraught and wanting to see you. I think it needs to be somebody who's suicidal and needs a treatment plan put in place. But again, I'm not completely sure of this, so before you use one of these codes, take a look at something more official. Okay, so psychotherapy plus E&M services. When medical services are reported with an add-on psychotherapy code, the evaluation and management portion is not time-dependent, but the psychotherapy is. However, the psychotherapy and the medical services must be documented and timed distinctly so that it's clear what services are being offered when. So you're not supposed to be having a psychotherapy session where you're doing the evaluation and medication management during the session. You're supposed to have some period of time at the end or beginning or in the middle or someplace distinct. I personally do not believe that this is possible, as patients in psychotherapy talk about what is important to them, and they may intersperse their concerns about their symptoms, their medical problems, and their medications throughout the session. Okay, so what's it okay to do? And because this has not yet been implemented, we really don't know. Presumably, most psychotherapy sessions will be coded with an E&M code of 99212 or 99213. However, I heard a speaker last night say that he thought psychotherapy sessions should be coded with low E&M numbers. It seems to me that 99211 would be appropriate if there were no medical concerns at all and the only medical intervention was to ask a patient if they needed refills or to write a prescription. This is my personal opinion. 99214 would be appropriate if a patient is having a complex problem requiring reconsideration of their diagnosis or side effects, or the question of whether their medicines or their symptoms are being confused with a medical complication that may influence their psychiatric status, and that tests and consultations are being coordinated. This is also my opinion. 99215 might be considered in a suicidal patient requiring hospitalization, but it is unlikely that the psychiatrist could manage that while documenting a review of multiple systems and a detailed exam that the 99215 requires. And what's going to be accepted in terms of adding on psychotherapy to these E&M codes is really not clear at this point at all, in terms of what insurers will reimburse for. This is all still just my opinion. And you'll notice the YouTube was free, so you're getting what you paid for. So here's some financial things to think about. We don't know what insurers will allow. Psychiatrists who participate with insurance will want to maximize their reimbursements. Those who don't will want a code so that their patients are able to obtain maximum reimbursement for out-of-network services. Will psychiatrists gear their sessions towards increasing documentation to justify higher codes and reimbursements at the expense of more targeted and appropriate care for each individual patient's needs? How does this affect psychiatrists who do not participate with insurance? Will they be subject to audits? How will it affect patients when each session will have an unpredictable fee or an unpredictable reimbursement if the patient is paying out-of-pocket a set fee and getting reimbursed? Presumably, out-of-network physicians will hold their fees steady, but patient reimbursement will depend on how the sessions are coded, and this may vary. I said I was going to just present the facts, but I get to put in a little bit of my opinions, and the ethical issues here are, do we want our doctors thinking about their patients and what might be best for their patients and what the psychotherapeutic process is yielding, or what their diagnosis is, or if their medication should be changed? Or do we want them thinking about what elements and bullet points their notes must document for reimbursement? How is a psychiatrist supposed to do their work, much of which includes active listening, if they are busy collecting data, which may well be irrelevant to the patient's care, or remembering complex algorithms and trying to decipher which parts of the session are psychotherapy versus medical management? And as I've said, I would contend that this is impossible. Do we really think that this makes for good patient care? Not one word of this series was about diagnostic accuracy, treatment choices, empathy, and being a good psychiatrist. Finally, I'm going to ask, what was wrong with the self-explanatory codes we had, which didn't require hours of study, manuals, courses, graphs, and pages of charts to code what we did, and then going to a YouTube video because we still couldn't figure it out? I'm titling my last slide "Really," and I'm doing this because I started this project because when I can't work my vacuum cleaner or I don't know how to keep the guacamole from turning brown, if Google doesn't tell me, I go to YouTube. And when I couldn't figure out how to do CPT codes, I went to YouTube to look for one to explain the changes to me. And when I didn't find one, I decided that I was going to be the one to make this to help other psychiatrists easily learn the coding changes. I also write some columns, and I thought it would be good to write about it. I had no concept of how absurd and unnecessarily complex the details would be. And so, while I hope this was helpful, I don't believe any of this is about what being a caring and competent psychiatrist is about, and I only hope that I continue to treat patients with the individual attention they deserve, and not as data generators for templates. Thank you for joining me. I'm in a state of being pretty distraught with the American Psychiatric Association at the moment. Hopefully these things will work out and things will go smoothly in January. Thank you for listening to my slideshow. Another place you might want to check out is there's a psychoanalyst in New York City who has a blog called Psych Practices, and she has been writing about CPT coding for psychotherapy and has included rather long charts about off the CPT manual or the E&M manual.